All right. Welcome back, everybody. We are going to get started with our afternoon. Just as a reminder, use the Q&A and chat features to ask any questions, or if you would rather speak a question or comment, you can use the raise hand option, all located at the bottom of your screen. And if you use the raise hand option, we will allow you to talk and unmute you, and then you can ask away, and then we will return you to attendee listen only mode. But this session is designed to be interactive. So type your questions away in the chat, in the Q&A. If we could keep questions to the Q&A, that would allow Ariel and I easier access to keep track of them, but any option is fine with us. So we are going to start our Ask the Medical panel. Before I introduce the panel, just kind of keep in mind that, you know, our panelists do not know your history or specific injuries. So if these questions could kind of be more general, that would help, you know, more people. They can't speak to your specific questions because they don't know your history, and a lot of things have to do with your certain history and things like that. But any questions, ask away. Again, the Q&A function would be our preference, but the chat, raise hand, any of them work. Okay, Angela Majorly is not able to make it to this panel anymore. Something had come up and she needed to take care of her patients. I do have her handout or her slides and a resource guide from earlier that I will be sharing with you all. So just be patient with that. That is coming. But also on the panel joining us is Dr. James Wilson. He is the Director of Spinal Cord Injury Medicine and Fellowship. We have Dr. Elizabeth Dreben, who is the Rehabilitation Psychologist for MetroHealth. We also have Bridget, Blayney, and Laney Dalsky. Both are spinal cord injury nurses. And then Gillian Gullan is an occupational therapist at MetroHealth. So any questions, feel free to ask. I don't know if our panel wants to do a little bit better of a job introducing themselves. If you have like a specialty that patients or the attendees can ask you, anything like that. I'm going to stop my screen. Okay.
So, you know, thank you so much for having us here. I don't know that I have any more introduction for myself, but I guess if people are having trouble coming up with other questions, I'd be open to hearing also about people's experiences, especially with the inpatient rehab and time after that. You know, I know that not everything is perfect, but I'm always kind of looking to figure out what the community, what the larger goals are for people in that kind of setting. So I'd be interested to hear your feedback as well.
While we are waiting for questions to come in, I think something that's on everybody's minds right now is, you know, the global pandemic that we're in, and if there's any impacts specifically for spinal cord injuries that we should be aware of, that you've seen, anything like that.
Well, I think it certainly affected you know, people's everyday function, their nursing care, their psychological health. So I think probably everyone on the panel could speak to this. In general, people with spinal cord injuries tend to be at a higher risk of getting something like COVID, and also more susceptible to have it be a kind of tougher course after they do get it. So we kind of recommend that you take all the precautions everyone else would. As things are loosening up, you might be on the more conservative side in terms of trying to continue social distancing, wearing masks, good hand hygiene, all those kinds of things. Our patients have been impacted by the lack of supplies. I think that's improving now a couple of months after the pandemic started, but initially there was a run on gloves and all those other kinds of materials that people use every day. So luckily the Craig H. Nielsen Foundation gave us a grant to help provide COVID relief supplies like gloves, cleaner, thermometers. We worked on a couple different projects. So there's still supplies out there. If you're interested, you can reach out to Megan or anybody else to try and get those for you as well. A little bit harder for people if you're internet or national or kind of at a distance, but we'll see what we can do. Dr. Dreben, could you comment at all about, we hear a lot about people with feeling isolation, feeling isolated and sometimes hopeless in terms of trying to follow all the guidelines from the COVID-19, trying to balance what's putting them at risk versus their good mental health. Do you have any suggestions about that?
I think trying to stay connected to people is super important, and limiting the amount of negative news. Not only do we have the COVID stuff now, we have an incredibly tense and in some ways damaging political situation right now. And the people who are so focused on news often have a much harder time functioning and getting through the day. So if you sort of think about being kind to yourself and reaching out, phone calls, FaceTime, any connection with people where you can shift your focus and sort of have a breather, I think is super important for all of us. When you're more isolated with a serious disability, it can be even harder. And that's why the social connectedness becomes more important as a balance, as a neutralizer of all the tension. So, there are a lot of things on computers now which are not always available. For example, the Library of Congress released all these free movies for people to watch. You can go to the Cleveland Museum of Art and do a virtual tour where you select which art you want to see. All these things there's no charge for. Many museums are doing that. Many music things are being streamed and available podcasts and stuff that often there's a charge and now there's not. So there's a lot of things you can do, even if it's not talking directly with another person, where you feel more connected and less isolated. And I think things like that are really helpful.
So we do have a question. Greg, you might have to elaborate on this, but he wrote, what if you are a person that did not go through the Metro Rehabilitation Center program and is partially paralyzed?
If you're talking about the relief supplies, it's not directly connected to to Metro. That we have a research grant, and it's working with United Spinal in some ways, but certainly you don't have to have a doctor here or follow here. We're happy to help out. It's supposed to be for spinal cord injury, but if you have other kinds of spinal cord dysfunctions or MS, whatever else, we're happy to kind of bend the rules for the greater good.
Yeah, so Greg, if you have my contact info, send me an email, text, whatever, and we will get you hooked up with some supplies. And then as a caregiver, can they get supplies to aid in protecting their patients?
Oh, sorry. Yes. So, you know, if you're the caregiver, if you're the patient, you know, it's the same role. Um, I mean, I imagine if you're a paid caregiver for a family member, that's fine. If you're just a home health aide that works out in the community, hopefully your organization supplies you with those things. But yeah, I mean, anyone that needs them, please feel free to reach out. Sometimes, you know, especially with the masks, you know, we have some disposable masks, and my intention is that you're giving them other people. You're not necessarily wearing them yourself all the time. But um, people definitely have concerns about caregivers and therapists coming into the home. Gillian, do you know, would you be able to comment at all about the earlier work that the therapists were doing with telehealth and how that was going? Oh,
Thumbs up.
not
No.
getting you. No.
How about now? Anything? Yeah? Okay. Okay. Unfortunately, I cannot. That's more of an outpatient basis. Um, I know that they're supposed to be seeing up to 40% of their caseloads through telehealth, but I know it was very challenging with the spinal cord population. So I don't know what that actually turned out to be and how it relates to how they're able to distribute. Sorry.
I think all the different medical institutions were trying to, you know, I know the psychologists are very active with the telehealth. The medical providers, we certainly have visits available for telehealth if you want to try and stay more isolated, but still have some services. So
I've been doing primarily telehealth actually with outpatients, and the nice thing with the video visits is you don't have the barrier of the masks. So for really connecting and relating, there's something really good about that.
Megan, you're muted.
Yes, I am. Okay, Elizabeth, to answer your question, yes, we do have rubber gloves that you can request through the grant. Send one of us an email. We'll put emails in the chat, and we can get you hooked up with some. Okay, there are some coming in from, okay, so Dawn Shiplet, who is a assistive technology professional, I think is the things. Sorry if I'm messing that up, Don, but he works for Miller's, and he wanted to comment that telehealth works well for equipment recommendations when replacing existing items. Okay, and then Ariel put both her and my email in the chat. So if you do want some supplies, send one of us an email and we'll start to coordinate that. Okay, and then in the Q&A, it says, sorry I was late, so I missed the intro, so I'm not sure if this question is appropriate, but what about taking supplements with spinal cord injury? I read a lot about supplements related to UTIs, like D-mannose, turmeric, apple cider vinegar, CBD oils for pain and spasms, etc. So I don't know who wants to comment on that, but what about supplements for spinal cord injuries?
So supplements as a rule are not well studied and they're not well evidenced. So in general, most supplements are safe, but not necessarily, I can't guarantee that they're going to work. So some of those have better evidence behind them than others. The D-mannose, I think, has better evidence. Even sometimes cranberry, there are a couple of different kinds of supplements that people take to try and prevent UTIs. I've heard about the apple cider vinegar, but I don't know that I've seen a lot of studies saying that it works or it doesn't work. There is, I think, more information out there about probiotics, about trying to make sure that you have a good bacteria in your bladder instead of a bad bacteria in your bladder, the same way that they do with the stomach. But I mean, certainly I don't think the apple cider vinegar would hurt you, but And then turmeric, you know, they talk about it as an anti-inflammatory properties. Same thing. I don't know that I have a lot of good research saying one way or the other, but anecdotally or based on people's experience, for joint pain and things like that, there has been, people do use that, and I certainly think it's safe. And if you're having trouble with chronic pain, it wouldn't be a bad thing to try. In terms of the CBD oils and marijuana in general, we're in this kind of awkward time of history where marijuana it's legal some places, it's medically legal some places. Right now, I mean, there's still, they recently rolled out the medical marijuana, but many of our patients are finding it just too expensive to use. And you know, you can get CBD oil at the gas station. So I hear a lot of positive things, and personally, I think about it like a medication, that it's got side effects and it's got risks, but probably all the medications I prescribe also have side effects and risks. So I don't think that marijuana and CBD oil are more dangerous than other things, but they certainly have side effects between feeling sedated, feeling you know, weight gain, things like that. But I do hear from a lot of people that it's helpful and that they prefer those kinds of treatments over, you know, other kinds of pills that can certainly also affect your brain. So I'm supportive. You know, none of the doctors at Metro prescribe marijuana, but it is out there. It's available for people now.
The psychiatric community is worried about marijuana for people who have underlying psychiatric problems such as bipolar, schizophrenia, even sometimes severe anxiety. The relaxing effects of marijuana on many people without those conditions is what people talk about all the time. But if you have a serious psychiatric disorder, unfortunately, marijuana can lead to people really decompensating and falling apart. So most psychiatrists are very concerned if someone has a serious psychiatric problem that they don't on their own try marijuana. It can have really the opposite effects from what happens in other people.
And something that I want to mention, just as somebody that does all kinds of education and learning on supplements and healthy living and wellness and things like that, is you really have to, whatever supplements you take, you know, work with a medical professional for sure, but you need to know the quality of the supplements. You have to know where they're coming from, trust the company, and make sure that it is the high quality supplement that you're after and not additives and fillings and things like that. So for whatever that's worth. Okay, anything else about supplements before we move on? Okay, so then a question no one wants to ask: what's new, if anything, out there for bowel routines, bowel management? Sometimes leaving a home for fear of accidents is overwhelming and no one ever addresses the issues or brings it up.
So the nurses think we're gonna get this one. Here, when patients are with us in rehab, and we know it's kind of frustrating, we do the bowel routine usually in the evening. And usually we try to educate the patient, you know, on the medications that we use here at Metro, which is usually the Colace, the Senecot, and then a Duplex suppository. I don't know if any of the participants can speak to Enemies, because Enemies is another suppository type medication, but we have found that it's expensive, and usually patients can't afford it when they're discharged from us. So it's like we'll get them hooked on the Enemies, and then when they go home, they find out that it's really expensive, and they can't use it. We also try to do a good job at educating them regarding their diet. So a lot of times when you're in the hospital and you know, you're getting like 3 meals a day and it's hospital food, which is generally healthy. You know, when patients go home, now they're eating, you know, foods that they weren't eating here in the house. Maybe they're spicy foods. So we just try to get them to kind of pay attention to maybe certain foods that they're eating. I think it would have to be looked at on a case-by-case basis, just because, you know, whatever other medications they're on. And if they want to, you could, I can put my email in there as well, and maybe kind of just look over her medications and things like that, and maybe and talk to her, because I think everybody would be unique.
Finding out what works well for each patient, and each, you know, spinal cord injury or cases can be different, and different medications will work, different techniques will work. It just depends.
Some simple suggestions I tend to give people. It takes much more time than you might expect for things to get from your mouth down to your bottom. So you really have to be patient with these. You know, try not to make changes every day or even more than about once a week. That you want to try and get into a routine, be consistent. Some people, they're constipated for a week or two, and then they take an enema or they take a big laxative and they have a big bowel movement, and then they're kind of having trouble for a couple of days, and they get into this cycle of constipation, diarrhea. We'd really rather, you know, stay on a regular routine. And then, like Bridget and Laney were saying, the diet really has a big impact. So if you can be consistent, you know, we do like fiber. We don't want you to take too much fiber. That can be a problem too. But if you go 1 week eating fiber all the time, the next week just having McDonald's, you know, it's going to be different. And your reflexes are usually more kind of hyperactive, so it doesn't take as much to kind of tip you over the edge. So it's for your benefit. And then just staying appropriately hydrated. You know, chugging down lots and lots of water isn't going to be better than just being regular hydrated, but don't get dehydrated.
Any other questions?
I did see something in the chat or the comments about the magic bullets.
Yes.
I believe, is that a name brand of Duplex? Because I want to say I thought we looked that up once and it was Duplex, but I don't know if it's like a name brand.
Yeah, it's the name brand, or it's a specific kind of the bicicodal suppository. So the difference is the generic one has a wax base, and the magic bullet has a water base, and so it melts a lot faster and works faster. So the studies that they've done, the magic bullet works faster than the regular suppository, and the enemies works faster than the regular suppository. Unfortunately, they're both a little more expensive than the regular one, but if you or your insurance can afford it, then usually we suggest the other one. Because otherwise, you know, if we can cut your bowel routine from 60 minutes to 30 minutes, it makes a big difference in your life sometimes.
I have a silly question. So would a doctor have to prescribe like magic bullet?
I don't think so, no.
Okay.
They do need to prescribe the enemies though.
Okay.
Specifically.
I think you can get them both over the counter, but for your insurance to pay for it, you're probably going to need a prescription. So.
Yeah, and just one more thing related to the bowel routines, mini enemas or the enemies work great. And then she does a finger stim and had bladder surgery 19 years ago using her bowels. Richard orders them over the phone. Okay, and then, so I guess a new question. My husband finally got stoma and he is glad. Made a big difference. Do you talk with people now about that as an alternative?
So, I mean, the answer is yes. So what the question writer is talking about is a colostomy or something like that, where they, instead of your colon going to your bottom, they change it so it comes out your stomach. It goes into a bag on your front there. Now, for many people, that first conversation is intimidating, that it sounds kind of brutal and kind of the cosmetic side is not that good. However, when we talk to people after they've had a surgery like that, the vast majority of them are happy that they had it done. That It's something that many people can take care of themselves. Even if you don't have the trunk support to go around and do your own bowel care, you can handle the bag on your front. Even if you don't have good hand function, a lot of times you can still manage a colostomy bag. And there's just not that surprise factor that it empties into the bag, it's sealed, there shouldn't be any big smell or anything else. That if you're the kind of person that's at home and you're afraid to leave the house because you don't want to be incontinent, then this might be a good option for you. That it's a little bit of a commitment, but for a lot of people, it improves their quality of life a lot. So we really should probably talk to people more earlier about it than we do. A lot of times we wait and let people fail for 6 months, a year, or even more before we bring it up. We should talk about it earlier on. But the other thing, if you have wounds on your bottom, it can be important to help your wounds heal. Gillian, how much hand function would you say someone needs to be able to manage a colostomy on their own?
On their own, I would think quite a bit. The nurses probably actually have better information than I have as far as the colostomy management. Different than the modified cath bags that we have. I don't know that the colostomy bags really have much modifying to them. I think it actually requires quite a bit of fine motor skills. What do you guys think, Bridget or Laney?
I would say either if they're doing it independently by themselves, they would definitely need the fine motor. But I mean, there's something they could do. They could do with assistance.
Yeah, even
maybe they could get it into a container, and then their loved one or caregiver, would have to empty it for them.
Yeah, and it's easier for the caregiver to manage also.
If you think in terms of that confidence factor and you reframe it as a really useful strategy or tool, then some of the awkwardness can go down. I mean, lots of things with disability, if there's a choice that helps you feel more secure and independent when you're out and about, and that's the public side, and it helps you feel more normal, a lot of times psychologically, that's really worth a lot. And even if initially you sort of clutch and feel miserable, letting it percolate and thinking about, would this give me more independence and freedom in lots of situations, is really valuable. And if the bowel routine has a lot of caregiver help already at home, you're not trading in more help. You may be trading in more freedom when you're out.
Yeah, I would agree with all of that. Even if you take fine motor into consideration, it's going to be a lot more difficult to clean up a traditional bowel accident than just emptying your colostomy bag. Yeah, and being out in the community.
As a nurse, I still have to mention that what you eat will still impact your colostomy. We have had colostomies explode and things like that, so you still have to pay attention to diet.
Rhonda mentions that she's a quad and she has a peer mentor from the Christopher Reeve Foundation. That mentor told her that enemies is what a lot of us in the spinal cord injury world use, and that it works in 10 to 15 minutes. And then Elizabeth asks, where around the stomach side is the colostomy bag?
It depends person to person a little bit, especially if you've had other stomach surgeries or things. But usually it's on that lower left side, kind of where that's kind of where your colon ends in your body. So that's usually where they put it. It should not be painful. It is a surgery, so there are surgical risks to it. Usually the most common is that sometimes you can get a little hernia around the area of the opening there. That's something that they can also address if they need to, but it shouldn't be painful. It is also potentially reversible, that if you get it, you don't like it, it would be another surgery to put it back, but it's a possibility.
And then another question. Okay, so the enemies are the mini enemas that you can purchase instead of like a suppository. It's just a little container that you squeeze the liquid into. that area. And then that allows everything to come out. And then one more question, as it is 1:30. Do T12, L1 have sensations, and are they painful? Is the question.
I'm guessing that was in regard to the colostomy. It would be, so the colostomy location would be above your T12, L1 level. So it would be in that area, but after the surgery finishes healing and everything, it shouldn't be painful. Yeah.
Awesome. Okay, so is there any last question? Okay, so we are at the end of our time. So thank you all for providing the questions, providing the answers, helping us out a little bit. Thank you for taking time out of your day to be with us today. Thank you.
Thank you for having us.
Okay, so I'm going to stop the recording.